Hello and welcome. I'm Jeunesse Castonguay, VP at Clarius. We're excited to see you all for today's live webinar, Facial Filler Danger Zones, Ultrasound Protocol for Safe Injections in the Chin, Forehead, and Marionette Lines. Today we'll be joined by educator and aesthetic dermatologist, Dr. Verner, who brings more than 20 years of experience, including having served as president of the European Society for Cosmetic and Aesthetic Dermatology. After injecting blindly for years, Dr. Verner discovered ultrasound and has been refining her techniques for over 2 years. She considers ultrasound to be a breakthrough in the field of aesthetics, and today she's here to share her best practices with us. Before we get started, I'd like to welcome all of you. You're among over 1,700 dermatologists, medical estheticians, plastic surgeons, nurses, physician assistants, and other clinicians who registered for today's popular event. Good morning, good day, good evening, depending on which corner of the world you're joining us from. A housekeeping note, please feel free to use the questions box at any time during today's webinar, as there'll be a live Q&A session following the presentation and live ultrasound scanning. It's now my pleasure to introduce you to Shelley Gunther, your host for today's event. Shelley is an experienced sonographer with 25 years of experience as a clinical ultrasound expert. As clinical manager at Clarius, Shelley is dedicated to providing the highest quality educational content for clinicians looking to add wireless ultrasound to their practice. She helps us deliver practical webinars like today's and video tutorials for our Clarius Classroom, which now features over 200 on-demand tutorials. Join me now in welcoming your host. Hi, Shelley.
Hi, Jeunesse. Thank you very much. I'm so excited to be hosting this webinar. It's our very first with Dr. Verner. So as we are well aware, the use of dermal fillers is on the rise worldwide. So our topic today will be of interest to many practitioners in the field, as we see from the number of registrants for this webinar. I'm pretty sure that no one wants to experience complications of any kind in their patients following injections, but unfortunately there are risks associated. But thanks to passionate experts like Dr. Verner, the use of ultrasound truly does help to minimize those risks, which is why the interest in ultrasound is continuing to increase among practitioners like yourselves. It's absolutely all about being able to visualize under the skin, to be able to identify vessels, as well as precisely targeting the area being injected. It really ensures better, safer, and more consistent results. Now, to set the stage for the presentation, I did a little bit of a literature review, and this first slide is a review article from Dermatologic Therapy. After reviewing research from the last decade or so, it was evident that vascular compromise is one of the most severe adverse events that can occur when injecting fillers in the face, including the glabella and the chin. Their goal was to identify these danger zones and make subsequent recommendations on how to avoid adverse events. Now, this is another review article, fairly recent actually, and it was done to assess and compare the type and severity of complications in various areas of the face. And after reviewing 46 articles and a total of 436 complications, they found that most severe complications occurred with injections in the areas of the nose, the glabella, and forehead. And some of these are what Dr. Verner will be discussing in her presentation today. And this final article really provides a solution to the complications that we've just talked about. It's from the Journal of Cosmetic Dermatology, and it describes a technique for using ultrasound for HA injections in the face. Again, the emphasis is on avoiding complications by first performing arterial mapping, then ultrasound-guided injections, and then assessing the perfusion of the local vessels following the injection. And the authors conclude that Doppler ultrasound for HA injections will likely be mandatory in the future. So we'd like to do a little poll now just before we get the webinar underway. What do you see as benefits of adding ultrasound to your aesthetic practice? Is it about better understanding and actually seeing the facial anatomy, including the vascular structures in the face? Are you worried about complications? Do you see a lot of patients with existing fillers but don't know how to treat them? Or do you just want increased referrals? So we'll give this just a couple of more seconds. 3, 2, 1. Great. So most people are worried about reducing the amount of complications that we're seeing. So I think the information that Dr. Verner is going to provide us with in her webinar is going to be really, really valuable. So let's get on with the webinar. It's my pleasure to introduce Dr. Inez Verner, who joins us today from Tel Aviv, Israel. Dr. Verner is a specialist dermatologist and has been working in the field of aesthetic dermatology for over 20 years. She's on the scientific committee of multiple international congresses, on the editorial board of several journals, wrote several book chapters, and in her spare time, also lectures and teaches aesthetic and cosmetic dermatology. Dr. Verner, I'll hand it over to you to share your techniques for performing safe filler injections.
Yes, thank you, Shelley. Thank you so much for the introduction. And I'm really honored to be here with you. For us, it's tonight. And actually to share my experience, how I work, and how we actually do it in the clinic. So actually, what's interesting is that the ultrasounds just a few years ago were very large machines, very difficult to put in the clinic, and they were also very expensive. But since a few years, we actually have, with the advent of technology, small handheld devices that are not so expensive and that are very, very easy to introduce into the aesthetic clinic. So, and actually the ultrasound that we are talking about here, the L20 HD3, is actually a handheld wireless device. You can see the image on your iPad or on your phone. It has unlimited cloud storage and, interestingly, a very good frequency to visualize what we need to see, to visualize the vessels up to 0.5 millimeter of diameter, and actually we are able to see up to 4 centimeters in depth into the tissue, which is great because we can see the skin and also the muscles and the bone and actually all the structures that we need when we use the ultrasound in the aesthetic clinic for injections or other treatments. So, and as you all know, and as was said before, there are many procedures performed each year, non-invasive procedures. We perform many filler injections, and the filler injections and botulinum toxin injections are on the rise. And even though we are safer now and we have quite good fillers, still we do see more complications because just the quantity of procedures went up and is going up. So, and the two main complications that we see with fillers are delayed inflammatory reactions, which are late reactions to filler, or vascular occlusion due to intravascular filler injection, which is actually the most severe complication that we can have because it can lead to tissue necrosis, to ulceration, to scarring, and even to vision loss. And because the anatomy is so variable, we really need to learn, we need to study anatomy. So we've all been to many cadaver courses, but still the cadaver that we saw is not our patient, and every patient, every single patient is different. And this is why the best technique for now is to do actually live ultrasound mapping before the treatment on the patient to really see what is happening there. And at the moment with the ultrasound, we can actually visualize. We can visualize the skin and the fascia and the fat pads and the muscles and the vessels. And we can actually visualize previous filler that was injected in the past. And I'll show you that also in this presentation. We can map the blood vessels in the danger zones before we inject the filler. We can actually see many of the vessels that there are. And in this way, we can prevent intravascular filler injection and its complications. Also, we can actually visualize when we have a complication of a filler, we can visualize this, we can actually see what's happening there in the tissue, and in this way also assist in the treatment and in the follow-up of this complication. So I'll talk in this presentation about the role of diagnostic ultrasound in aesthetic medicine, about vascular occlusion, and also about vascular mapping to prevent intravascular injection, and I'll show you some video demos. But first, a few words about ultrasound. So ultrasound waves are actually pressure waves, and these pressure waves actually give us, when we measure the bouncing back of these waves, we can measure the amount of waves, the signal that these waves are actually giving when they bounce back. So when the image is anechoic, like here in this one here, then what you have is that you actually have no waves that bounce back. And this is fluid. And many times when we inject hyaluronic acid, this will be the image that you will see. The other image is hyperechoic. And the hyperechoic image, there are many waves that bounce back. And this could be bone, for instance. Bone will be white. You see it on the ultrasound image. Hypoechoic is actually this where there is like a mid-range of waves bouncing back, more, less. It's in the middle, but in this image is something like hyaluronic acid that has been in tissue for a longer time, can be hypoechoic, and isoechoic is when the image that you see has the same bouncing back as the tissue around it. And here you can see actually an image with multiple deposits of hyaluronic acid, and two areas are black. So they are anechoic, and this should be a recently introduced hyaluronic acid in tissue. The other area is hypoechoic, and so this could be a longer standing hyaluronic acid that has been longer already in the tissue. But what's so nice here is that hyaluronic acid is actually so easy to visualize with this technology. So we can actually inject and we can see where the filler is, or we can see where the filler has been introduced before. Now, what is also very, very interesting is the different fillers have different patterns in tissue. For instance, polylactic acid, PLLA, will have hyperechoic and anechoic balance. So this is due to these fibrotic areas that are there due to the injection of the filler, and this is seen here. For instance, silicone, actually I had a patient today who had silicone in her lips, and I checked it and I saw exactly this pattern, this fine grain snow foam pattern. All the area was like fine grains. You actually don't see the tissue, and all the tissue that is under this area is kind of black, obscured. Very, very interesting. The calcium hydroxyapatite gives kind of a coarse grain snowfall pattern, as in this image here, and here in this one. And also polyalkylamides, they have a very specific image. So this is very interesting because with time, when you inject, you will learn, or you learn, and me too, to recognize all these different fillers. And many times patients come to our clinic and you ask them, have you had filler before? And they say, well, maybe 20 years ago, maybe 10 years ago. And then you check it. And many times you can still see the filler there, mainly for the tear trough area, but also in other areas. Sometimes fillers stay much longer than we think in tissue. And this is something that we can easily visualize with the ultrasound, also other fillers than hyaluronic acid. So another point that's very, very important, because we're talking about vessels here and about safe injection. So we need to know that to visualize vessels, we naturally need to use color Doppler. And the color Doppler, actually, when we see it, the red color means that the blood is flowing towards the transducer, and the blue color means that blood is actually flowing away from the transducer. And in this image, for instance, there are some areas where the blood is flowing towards the transducer, and this here, blood is flowing away. So that's also something to understand when you see the image. So we'll go over to vascular occlusion. So as we said, and those who have experienced the vascular occlusion know that this is the most horrible complication that we can have in aesthetic medicine, because this can lead to skin necrosis, it can lead to scarring, and even to blindness. And in this article, actually, this was a study, this was a cohort among 370 dermatologists who were asked if they had ever a vascular occlusion and how they are injecting, either they use a needle or a cannula. Now, what was found is that even when doctors use a cannula, there is a risk for a vascular occlusion. It is, of course, more rare than with the needle, but the risk is not zero even if you inject with a cannula. So this is very important to understand, that there is never a zero risk, and that we always risk an intravascular injection. So, and fillers may cause blindness if a column of filler is actually injected against the blood pressure. And so here, for instance, you can see that if you inject the dorsal nasal artery and the filler flows through here, it can actually reach the ophthalmic artery. And in this way, it can cause blindness, which is very severe, of course. And the greatest risk to cause blindness are the forehead, the glabella, or the nasal dorsum. High risk is in the temples, in the nasolabial folds, in the periorbital area, in the medial cheek, and less risk is when you inject the lips, the perioral region, the anterior cheek, and the lower risk, of course, when you move away to the jawline, to the marionette lines, lateral cheeks, and the other areas. But what you have to remember, that there are anastomosis there, and there are interconnections between the vessels, and we really never know how these and where these anastomosis are. So here, for instance, there could be a retrograde flow from the supratrochlear artery into the ophthalmic artery, and it can lead to vision loss and ptosis, and you can also, there may be some entry into the retinal artery, and then there is, of course, a vision loss. Now, this vision loss is very rare, actually, because it happens just in 1 in 100,000 cases, injections or injection syringes. But of course, because it's so severe, this is really, really something that we would like to prevent. So we'll go over to vascular mapping. So by ultrasound mapping, we can actually visualize the vessels and map their depth and plane. And the newer ultrasound transducers can actually visualize arteries that are even 0.5 millimeters in diameter, which is great because the diameter of the supratrochlear and the supraorbital arteries, for instance, is about 0.7, has a mean of 0.7 or 0.8 millimeters, which is really, so we can easily visualize the vessels that we need to see. And we don't see too little, but also we do not see too much with this ultrasound. So what is important is not to inject in the same plane. So if, for instance, you see a vessel at 4 millimeters, then you should inject either deeper or more superficial. And also you can move away. So when you see the vessels as a certain area, then you just move away and inject in a different, laterally from that. And this is actually very interesting. And we're gonna, actually with Shelly, we're gonna try visualize, do a patient with the supratrochlear and the supraorbital artery in a while. And actually this is very interesting because the frontal area is really, the forehead is a danger zone, even though we would like to inject the forehead many times, because many patients actually do have this hollowing. And also I can say that I've had some patients in the clinic who don't react so much to botulinum toxin, and or over the years they react less, or they just don't react so much. And the reason is that their skin is very lax, or they have this, I mean, they move a lot, but mostly what the solution would be injecting a filler in that area, and that could really help even solve the problem. So fillers here can, of course, compensate for the volume loss and reshape this area, and this will give a very nice aesthetic outcome. But of course, this is a danger zone, and it has been recommended to us to inject this area at the supraperiosteal plane, because the vessels, as we know, they go out of their foramens, the supraorbital and supratrochlear arteries. They go from deep, and then somewhere in the forehead, they are going to be more superficial. So when you inject there and you inject deep, then you may be safe. And so this area is actually really an area to take care. Also, the glabellar area is very difficult and dangerous to inject. And also what we know is that there is a change of plane. But what was very nice about this article is that it showed that the change of plane, the going from deep to superficial, is different from person to person. And what they did in this study actually is that they measured the change of plane, where the change of plane is, in 50 patients, in males and females. And what they saw is that most of the people will have the change of plane somewhere here, about a fifth from the brow area. So they will be, their change of plane of the vessels will be in the lower fifth of the forehead. But in some people, it was also higher or lower. So it's not exactly the same in every person. And this is very important to know, that this change of plane may be different. And even if you inject here, for instance, and you think that you should already be safe when you inject deep, this could be that you are not yet as safe as you think you are. So here, yes, we would like to administer, of course, the fillers in the supraperiosteal plane, and the ultrasound should be done also for the forehead. Remember, personally, I always use a cannula because it's safer, a blunt tip cannula. I don't use a 22, I do use a 25G in the forehead. Yeah, I do scan the vessels before, so that I know that I'm not injecting where the vessels are. So here, these are actually the images that you can see, and Shelly actually will show them to you, that you can see really the change of, we can actually visualize the change of plane, the arteries going from deep to superficial, actually really like moving up in the plane. And here, this is a transverse ultrasound showing of the forehead, the supratrochlear artery, and that it is here in this area, already superficial to the frontalis muscles. These are very nice things to see, to visualize, and to understand. So I'll show you now, this is a video from the clinic that we did, and what we can actually see when we scan the forehead is, of course, there is not so much tissue there. So you have just the skin and very little subcutaneous fat, nearly no. Of course, everybody knows we nearly have no subcutaneous tissue there. Then we have the muscle, and then under that, the bone. And here, actually, we already saw. So this is the supratrochlear artery there, because it's a little bit more medial. And the artery we can measure, and what I measured here was around 3 millimeters. If it will show I'm doing the measurement, so it's 3.5. You can see it there. So I'm doing, the measurement. There is actually now a new update with an AI program actually that will measure that automatically. So it will go much faster than what I'm doing here. And so you know that when in this area, the artery is at 3 millimeters, You can, inject either very, very superficial, or you can really go deep to the bone and inject on the bone. And then so that would depend where you want to inject, but most importantly, also, you can just move away from the area where the vessel is.
Yeah, it's incredibly superficial. And yeah, I think I would like to ask, like, now that you know, and now that you use ultrasound, can you imagine living without it?
Yeah, actually, yes. When you start using it, it's really, really difficult not to use it. Like today, I had a few patients in the clinic, and I'm getting quite fast in it. So I'm like measuring, I did the temporal area in a patient, and also the marionette line. So it's really, yeah, you're right. And especially the forehead and the glabella, which are really terribly dangerous. So these areas, for sure, I would always use that, because then you're very, very safe. So yeah, what is here, I think this was the supraorbital artery depth, and I think this was also the foramen there. So and actually it's easy. The foramen will be like a break in the bone when you see, because the bone here, for instance, this is the white line, this is the bone, so the foramen is like a break in this continuation of the bone. And now that, for instance, in her, yeah, we could go on and inject this her forehead. And actually, I do it now that I have to say, now that I have the Clarios, the ultrasound, I do it more often because I feel more safe doing it. Because before, I felt that I'm not safe, and then I would say to a patient who wanted that, I would say that to them, I would prefer not to do it. But now I can really do it quite easily and safely, and by using a cannula. So let's go over to the area, actually we'll go to the marionette area. And in this area, actually, we are close to the inferior, labial artery. And we know when we actually go closer to the lips and to the perioral areas, also, again, there is a huge variability with where the vessels are. And even though in 78 to 80% of the patients, the arteries will be submucosal, in some patients, they are intramuscular, so they are at a different depth. And in some patients, in 2%, they are subcutaneous, so they can be very, very superficial. So even if you think you are safe when you inject superficially, you are not. And so this is very, very nice to visualize the depth of the vessels, because if you visualize the depth, you can inject either deeper or more superficially. And here is actually a video where we map the marionette lines. And what is interesting here is that when you start scanning, and you can see that I'm scanning the marionette area, is that there is previous filler there. This whole black, this high, our anechoic area is actually hyaluronic acid that was injected before. And this is very interesting, because if, for instance, I would see that and the patient would complain of any problem, then it would be very, very easy to inject hyaluronidase there, for instance. And there are many cases like that. And also, I will show you a case later in this presentation where we actually dissolve hyaluronic acid after ultrasound. So here, actually, I mark where I saw the vessel. There was here you can see I measure the depth and I mark where I saw it, and so I go laterally from there, but also not in the same plane, not in the same depth. So if the vessel is here, it's 5.6 millimeters, then I can go either more superficial, so I can inject at 2 millimeters or superficial, or I can decide to go even deeper than that. And here I'm showing you the injection. And what is also very interesting is that when you inject after ultrasound mapping, you have nearly no bruising. So it's really nice, because when you move away from the larger vessels, and yes, of course, there are capillaries, and you can hit a capillary and not press, and then it will, of course, bleed on. But actually, if you press immediately after the injection and you move away, you can be completely actually have nearly no bruises. And so it's very, very nice to get patients out without bruises from the clinic. So this is after the injection. And then actually I visualize it again. And as you see, this area of anechoic area is actually larger, or there are two anechoic areas there. And this is because there is more filler now there. And also in this case, I did the Doppler again, and I saw that the pulsations of the vessels are good, and so the patient can actually go, and we didn't hit, of course, anything there. So I have to say that yes, of course, you can do this ultrasound after the injection just to be even more safe. But if a patient is in the clinic and they have nothing, no blanching, nothing on their skin, no skin changes or no discoloration after the injection, then of course the chance that you've hit something is zero, nearly zero, of course. So this is actually very, very safe. But you can visualize just to see that the vessels are pulsating right, and so everything is good. And so I'd like to
added reassurance, right?
Yes, this added reassurance, which is very, very nice. I mean, if you suspect that you may have hit a vessel, then you can actually check it, and that would be very nice, just if you see the pulsations, But, sometimes patients may have, for instance, a very severe bruise, and you see that immediately in the clinic, because the bruise, sometimes if you hit a vessel, you can see that. And in these cases, I think it could be very good to check if you see the pulsations. And so then when you send the patient home, you know that there was no intravascular compromise or intravascular injection there. And this is a very nice case, actually, that I want to present. This was a case of actually submental artery involvement after HA injection. And here, the filler that was injected was Juvederm voluma. Actually, in this case, they injected 2 cc of filler. And for me, I think it's a little bit too much. I think this may be the only point in this article that was quite a little bit too much, but all the other things that they did were completely right, because they injected slowly and they aspirated, and they just gave very little pressure when they injected. So they were very, very careful injecting the filler in the chin. But immediately after the injection, they saw actually blanching of the skin on the right side, and also the patient complained of pain. And 2 minutes after the injection, they saw kind of a picture with some levator reticularis pattern and some mottling of the skin. And so they actually knew that there was some intravascular filler injection. This was the picture 15 minutes after the injection. There was a discoloration, and actually it was kind of a demarcation of the ischemic area. So in the authors here, they decided immediately to inject hyaluronidase, and they injected hyaluronidase several times, a few days on, up until actually they saw some kind of improvement. So they injected it over 2 days after the injection. But still 5 days post hyaluronidase, there were skin changes. So there were pustules and there was crusting in the same area. But on day 7, the patient actually recovered without scarring, and they were really, really lucky here, because they actually diagnosed the intravascular injection immediately. So they were able to treat it. And here you can see the course of the submental artery, which is actually a branch of the facial artery, and it goes here under the mandibular bone, and then it enters into the chin, and goes up also from kind of deep to superficial. So the submental artery is the largest branch of the facial artery in the neck, and it has kind of a large diameter, and it passes at the area of the superior edge of the submandibular gland, and also has some anastomosis with the inferior labial artery. So there are always anastomosis with other arteries, and also this artery is an artery you don't want to hit, because you don't want to see any necrosis or to risk anything like that. Now here we're scanning the chin area, and what is interesting here is that you can very, very clearly see the muscle. You even see how this mentalis muscle is going here. So these areas that are anechoic and hypoechoic, actually one of the so this is very, very, very nice picture of the mentalis muscle. And then I'm going to do the Doppler also. And with the Doppler, here is we saw a vessel that actually, and I think it's most probably a branch of the submental artery, and it goes on the chin. It's already superficial, and we know that in most of the cases these vessels will be quite superficial on the chin, and this is why it is recommended for us to inject the chin deep. And so also in this case, because the vessel is superficial, the injection of the chin that we're going to do is going to be deep onto the bone, and actually quite deep. So it will be inside on the lower edge of the muscle. Here. And here, yeah, you can see the vessel there. And here, yeah, so what I do here, and this day I will do that for you too, is just to measure the height. And so you know the distance from the surface of the skin, the distance of the vessel. And so you can, you just inject at another plane, and you move laterally from there, not to be in the same area, and then you will be safe. So yeah. So we have to understand the safest depth for the injection, and it can be different in every patient. So that's very, very important. Also, the vessels, they cannot be in exactly the same area. And also, as was said in the article, it's important to not push too much and not to inject too much filler. Actually, personally, when I inject the chin, I tell patients that it may not be possible to give full correction at the first time, so that they will come again and we will correct it again, because not to give too much pressure to the tissue. And of course, cannulas are safer than needles, but if you use cannulas that are narrow, like the cannulas that have a larger gauge than 25, you also risk, actually, they actually behave nearly as needles. So a 27G cannula is actually very similar to a needle when we think of risk. So the cannula has to be with a lower gauge than 25. And also another point to make is that when you know that a vessel has a certain way that it goes, then you should inject in a perpendicular way to that vessel, because then injecting intravascularly, the risk for that is much, much lower. And of course, move the needle, for instance, inject when you in a retrograde way would also be quite good. So this is actually a patient of mine who came with this swelling of her lower eyelid, and she was injected 4 months earlier by a filler, and already she was injected by hyaluronidase, and the hyaluronidase that was injected was not effective. So what I did, I actually scanned her with the ultrasound in the clinic, and then I saw that the HA, there was just a very little area of hyaluronic acid when you look here, so just a very small part of this area had HA, and all the area surrounding it was actually more swelling. It was hypoechoic, so it was not due to the swelling was not due to the hyaluronic acid that was there. So what I did, I injected very little hyaluronic acid just where this filler was located. And this was her result after a few days. So that's very, very nice result. And she was really very, very satisfied. And so in conclusion, when we inject the forehead, we have to map the supratrochlear and the supraorbital arteries. For the marionette lines, it's important to map the inferior labial artery. Also, you can map the facial artery. It's a little bit further away if you like, but actually the inferior labial is very, very important in that area. And for the chin, map the submental artery, and these are the vessels that you need to see. And also, if you inject in a certain area that is a danger zone, just take the ultrasound, do a Doppler there, and if there are no, if you don't see any vessels, then most probably you will be safe there. So anatomy is important, and of course we have to know our danger zones. There is a huge variability between patients. Every patient is different, and left and right are different. And by vascular mapping of danger zones before injection, we can visualize the individual anatomy of our specific patient, and in this way prevent intravascular filler injection and its complications. And thanks, and yeah, follow us. Great. And warm regards from Tel Aviv.
Thanks, Dr. Verner. That was fantastic. And yeah, I have to say that in my short history of scanning facial vessels, there definitely is variability, not only patient to patient, but from side to side. So, you know, like I was saying, I don't know how anyone would live without ultrasound at this point, but I'm going to do a quick demo here. I have a model. We know she has existing filler in the chin, so I can show you how easy it is to identify existing fillers. Now I've gone into with the Clarius scanner and selected the aesthetics preset here. And what that's going to do is going to set our depth really nicely for looking at structures in the face. And it's going to give us a really nice image right off the bat. So I can just go up here and we can find our existing filler, which is going to be hypoechoic. And we're just seeing little pockets. She's had this filler for several months now, and it is a temporary filler. So it's not as big as it was when we first started, but we're seeing skin surface here and the filler, and this is the bone down here. And I'm just going to decrease my depth a little bit just to make that a little bit bigger.
Yeah, you can clearly see the filler, and that's very, very nice on the scans. That it really, yeah, many patients, like I said, sometimes they don't remember, or they it happens so often that and also yeah, filler stays longer than we think, actually, many times. So that's very nice.
Great. So I'll just turn the color Doppler on here, and we'll just identify some vessels here. So I believe this is the mental artery that you were talking about. Ooh, there we go. And so it's just kind of in the region of that filler. Being careful not to apply any pressure here. So we can see a couple of different vessels in that area there. And like Dr. Verner said, we can either measure the depth, or I can go in and use this feature called Auto Vessel Depth AI. And what it does is in real time, it's going to measure the depth of that vessel. Just make sure it's hard to talk and stay on here at the same time here.
But it was very nice. It was 4.2.
Yeah, it works really well.
Yeah, and that's actually what you need at that moment. And if when it's fast, because in the clinic we don't have time, you know, one of the is time. Yeah. So if you just can easily do it, that's the same.
And even if you're if you're not close to your iPad at that moment too, and you have that feature turned on, you don't have to kind of walk over to the iPad and let's turn this way a little bit. Actually, maybe I'll go the other way. Okay, good. So I'll just head up. So yeah, there we're seeing the vessel here, and we're seeing that it's only 1 millimeter deep. So in that particular area, you're saying you'd want to inject onto the periosteum in this area. Good. So I'm just going to turn the color Doppler off here, and we'll go up to the forehead. And again, very superficial. And I will turn the color Doppler on again, and we'll try to identify these vessels.
Yeah, and what is what you see here is that the space is actually very narrow. There is not so much at the forehead, so the distance from the skin to the bone is nearly nothing. And also because you're actually at the glabellar area, what we can see most probably this will be like the corrugator muscle, and maybe even the front parts of the frontalis that
so
are
right in this area here is the muscle, so it's more hypoechoic.
Mm-hmm.
Great. I'll just go live again here. So there's our vessel.
Yeah, this is very, very nice. This to see this,
Yeah.
But in the future, I think another work in progress will be also botulinum toxin injections with seeing where the this is I think a work in progress for the future. But I think for safety, of course, really seeing the vessel, seeing this vessel now, knowing that it's a 2.7, and if you inject and you just move away
you
from
just
there.
Want to go, or go, and we're not talking moving way away, right? We're just talking a couple of millimeters is going to make all the difference in the world, right?
Yeah, that's it.
Excellent. Great.
Yeah.
Good. Yeah, I could see with practice, with a little practice and knowing what you're looking for and having your machine settings optimized for doing aesthetics. I think it's something definitely achievable by everyone.
Yes. No, for sure. Achievable by everyone. Yes, sure.
So just before I hand it back to Jess, just a reminder to everyone to use the Q&A function, and we'll do our best to get to your questions.
Thank you, Dr. Verner, for sharing your expert best practices for safe fillers with us today. And thank you, Shelley, for the fabulous live scanning. It's always fun and exciting to see the Clarius L20 HD3 in action. Now, just before we open up the floor to your questions with our guest speaker, here's a quick poll for you. We'd love to help everyone continue on their journey of bringing ultrasound guidance to their aesthetic practice. So please do complete this poll if you'd like any additional information. Price and availability does vary by region, so feel free to request a quote and pricing for your region. You may opt to speak to one of our experts about the advantages of wireless ultrasound. If you'd like to discuss scanner features, please select that option. You can also book a virtual one-on-one demo with our expert to see the new Clarius HD3 in action. And we can send you more video tutorials. We've seen lots of questions where folks are looking to both do ultrasound for facial aesthetic applications as well as breast exams or Brazilian butt lifts. And if that's you, please select one of these options and we'll be sure to have someone follow up with you after the webinar. So while you complete the poll, I'd like to take a minute to introduce you to the Clarius L20 HD3, the world's only ultra high frequency ultrasound in a 20 megahertz wireless scanner. It's now 30% smaller and lighter with an integrated battery. Our new advanced aesthetic package includes AI-powered features to automate workflows like the vessel depth AI that Shelley demonstrated for us today. Since the 80s, ultrasound has been a recognized gold standard among plastic surgeons, but systems were traditionally costly and complex to learn with lots of knobs and buttons. Today, Clarius Ultrasound has changed the game in facial aesthetics. Miniaturization and innovation with handheld units means high definition imaging is now easy and affordable with image quality that rivals traditional systems, but at a fraction of the cost, representing savings well over 80%. The Clarius L20 HD3 is the only handheld ultrasound with ultra high frequency to 20 megahertz for exceptional superficial imaging to 6 centimeters for facial aesthetics. It's the leading choice for plastic surgeons, dermatologists, nurse practitioners, PAs, dentists, and medical estheticians. With this best-in-class high-definition imaging of skin, muscles, vessels, and fascia planes, you gain confidence in your needle placement. You can easily characterize and evaluate fillers, and you can more accurately treat complications, improving patient safety with consistent treatment outcomes. The secret lies in the technology, with each scanners featuring 8 beamformers, 192 piezoelectric elements, and artificial intelligence that together deliver the crystal clear image quality only found in traditional systems. Artificial intelligence replaces complex knobs and buttons, making the ultrasound imaging fast and easy to use. Claris is also wireless, freeing up space with zero footprint, and it's fully immersible, so it's much faster to clean and disinfect. Only Claris delivers wireless scanners with an ecosystem that includes a free app for your iOS or Android devices with free updates. And available with our new membership, Claris Cloud, can be used to easily capture and manage unlimited exams from anywhere. Your membership includes as well Claris classroom videos with experts like Dr. Ines Verner and Dr. MJ and Dr. Stephen Weiner, as well as onboarding with a Claris clinician to build up your ultrasound scanning skills. And Claris Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for second opinion. Also included with your membership, the new advanced aesthetic package offers more flexibility for users who need additional customizations for various examinations and procedures in the realms of facial aesthetic, breast augmentation, BBLs, hair follicle imaging, and more. For clinicians who prefer a one-time purchase over membership, the advanced aesthetic package is available as an add-on purchase. We'll now take up 3 seconds to close up the poll. 2, 1. Thank you for participating, and we'll get back to you in the coming week. I'd like to now invite you to participate in one final poll. We're excited for our next webinar, and you can pre-register today and join Dr. MJ Roland Warman, who is scheduled to do a webinar with us on January 19th. As a popular ultrasound educator based in Liverpool, Dr. MJ has become a renowned advocate for using ultrasound to prevent and resolve filler complications, and as such is often referred a variety of complication cases from other injectors. In her January webinar, she'll share 2 recent patient cases captured on video to demonstrate how to efficiently dissolve misplaced fillers in the forehead and tear trough with great accuracy for perfect results. She'll share her techniques for keeping it simple, achievable, and attainable. Please complete this poll to pre-register so that we can save you a seat and send you a confirmation email in the coming weeks. I'll give you 2 more seconds to save your seat. 2, 1. All right. I'd like to now welcome back Dr. Verner and Shelley for our live Q&A session. I do want to let everyone know that a recording of today's session, as well as a PDF copy of the presentation, will be emailed to you in the coming days. Please use the questions icon in the menu bar to ask your questions. Shelley, if I can ask you to moderate, please.
Thank you. One of the first questions, Dr. Verner, is do you offer training?
Well, up until now, no, but well, maybe we should start and plan it, and certainly when we will do it, we will let you know, and maybe in the near future we'll organize something together, Shelley. No? I think there's a need for that. Really, really huge.
I do too. Yeah. And more people are asking for it. So yeah, absolutely, there's a need. Do you use ultrasound for botulinum injections as well?
Well, I just started. My first project was the vessels, and now, for instance, when I'm doing the masseter, yes. When I'm injecting for masseter hypertrophy, yes. And I think I was just talking about it, that yes, we can use the ultrasound for botulinum toxin injection, even for the glabella, to really see where the muscles are, and exactly to actually point the botulinum toxin exactly where we need to be. For me, I just started doing it for the masseter hypertrophy, which is important because the areas can be separated, and so you really need to get the toxin in different places to get the right results when you treat the masseter.
But you can't see the botulinum after the injection, or can you? Like, is it something like filler that you can actually visualize it?
No, you won't be able to visualize the botulinum toxin, but you are able to visualize the muscle, and then you know where you need to be with the botulinum toxin. But it's a fluid, so maybe for no, you won't really see it. Maybe for very, very short It's water, and actually diffuses very, very fast. So no, I don't know if you're, but that doesn't, you need to visualize it.
Right. Okay. This question is about an occlusion, and when you have a probable occlusion, can you actually visualize the vessel, where the vessel is occluded to target your hyaluronidase?
Yes, you can. I have to say, luckily, I didn't have any vascular occlusion since the time that I'm using the ultrasound. So I didn't have a chance to, but yes, you can see that there is, you will not find the vessel, and maybe the flow will be very, very minimal. And so, and you can compare the intensity of the flow on the other side of the face and see that that it's just not there. So you have to inject a lot of hyaluronidase. And actually, when there is a vascular occlusion and you know approximately where it is, you just have to really inject a lot of hyaluronidase there.
And I think just from my experience with doing vascular ultrasound, you may see a lot of turbulence within the vessel. So you'll see a lot of colors mixed in rather than just the red or the blue, which, indicates turbulence. So that may be something where you've got a partial occlusion. Right.
Yeah. So that would be something to see. And then, but what is good that if you inject, for instance, in that area where you saw the turbulence, and you see that the vessel will start flowing, you will see again the flow, the blood flow in that area.
It'll be returned to normal again.
Yeah.
Okay. Well, that's great. We are at the top of the hour. So if we didn't get to your questions, we will be answering them by email in the coming days. And thank you very much, Dr. Verner. That was fantastic. Great presentation.
Thanks, Shelley. Thanks, Dr. Verner. A friendly reminder that you will receive a copy of the slides and webinar recording as well. So keep an eye on your inbox for an email from us. And please do complete our closing survey to provide your feedback so that we can continue to bring you more educational webinars like today. To conclude, again, a big thank you to Dr. Verner and Shelley for all of their insights, and a very big thank you to all of you for joining us today. We hope to see you again in the new year, our webinar with Dr. MJ on how to use ultrasound to efficiently and accurately dissolve misplaced fillers. In the meantime, keep scanning, and we wish all of you a warm and wonderful holiday season. Thank you.
Bye.
Thank you. Bye-bye.